everyone, I'm Emma.
I'm Kylie.
And thank you, Robyn, for asking us to present our talk from EFSHT in Italy last week. We presented during the orthotics free paper session, and we haven't actually adapted this talk since, so a lot of the theory you'll be familiar with. We completed Robyn's SIMS course back in 2020 and have been SIMS converts ever since. So this was our presentation from Rimini. Casting motion to mobilize stiffness, a game changer in the treatment of stiff hands. So we work in St. Vincent's University Hospital, which is an acute teaching hospital in Dublin. We cover a large catchment of Southeast Ireland, and our caseload is a mixture of both plastics and orthopedic patients. So today we're discussing the background for using SIMS, the technique itself, some of our case studies, and an audit that we did. So if we think about everything our hands allow us to do, they give us independence to care for ourselves and to care for others. They allow us to work, to drive, to play music. They provide strong, powerful grip and fine, precise dexterity. And there's this lovely quote which reflects the hand's role in communication and touch. And we often don't think about this until we have a hand injury, and we realize that for most things in life, we need two hands. So when we have prolonged stiffness after a hand injury, this can really have a devastating effect on people. So the background. So as we know, traditional hand therapy really doesn't work for every stiff hand. You get improvements, but they're often transient. And some of the treatments that we use can lead to pain, swelling, and further stiffness. Episodes of care are often quite lengthy, and this can lead to reduced patient compliance. So SIMS stands for casting motion to mobilize stiffness. And this isn't a new technique. It was developed in the 1980s by Judy Colditz. And in 2018, Robyn Midgley developed an online platform to deliver SIMS to a worldwide audience.
So SIMS involves selective mobilization of the proximal joints in an ideal position while allowing the distal joints to move in a desired direction and range. We can see in this video a patient attempting to make a fist 6 weeks post a complex distal radius fracture. She has an abnormal movement pattern, and instead of her fingers flexing, her wrist flexors are overactive. But by stabilizing her wrist and her MCP joints in a cast, we can redirect her energy to the distal joints, which have become stiff. So as well as improving range of motion and reducing stiffness, the casting technique has other benefits. The cast pressure and warmth reduces scar adherence and results in a softer, more mobile scar. In terms of edema, the constant active motion of the digits within the cast helps to facilitate lymphatic pumping, and that, as well as the light sustained pressure provided through the circumferential nature of the cast, helps to reduce edema. But probably most importantly, the cast influences motor cortex repatterning. So once the wrist is stabilized within the cast and the forces are redirected to the PIP and DIP joints, the patient engages in repetitive active motion. And it's this focus on active as opposed to passive exercise that cortically normalizes the grasp and tenodesis pattern. So there are some contraindications to the use of SIMS. Patients with claustrophobia, vascular instability, infection, work demands and driving. So patients who are being assessed for SIMS are generally in such a bad way that they can't drive or work anyway, but it is a consideration. And personality. So over the last 18 months of using this technique, it's really become clear from our experience that patient personality plays a huge part in patient outcomes. And it's those patients who are motivated and engaged and who buy into the rationale behind the technique tend to do better. There are also some considerations when it comes to the wrist and shoulder. So there is a concern that wrists may become stiff being immobilized, especially after those kind of distal radius fractures. However, we found that there is actually an improvement in wrist extension from being in the cast. And although initially wrist flexion is reduced, this is easily regained after return to function. In terms of the shoulder, we all know that upper limb patients are at risk of developing frozen shoulder. And this is something that's assessed and monitored throughout the casting process. So it's a consideration rather than a contraindication, and it's really assessed on an individual patient basis. So there's two principal types of casts. However, there are variations on these depending on the patient presentation. Patients that present with an intrinsic plus pattern of motion are put in an intrinsic minus cast that blocks the MCP joints into extension and allows that hooking motion. whereas patients that present with a dominant intrinsic minus pattern are put into a intrinsic plus cast, which involves a dorsal hood to block the MCP joints down into flexion. So we're going to run through a couple of slides or a couple of cases now. The first of which is a 31-year-old right-hand dominant gentleman who sustained a comminuted impacted right distal radius ulnar fracture with dorsal dislocation of the ulna, as well as that a comminuted proximal phalanx fracture of his right ring finger, required K-wiring, and he was referred to hand therapy 6 weeks post-surgery and removal of these wires. So in this first video, we can see the patient has reduced range of motion of his ring finger and little finger, not only due to stiffness, but also long flexor adhesions. He was put into an intrinsic minus cast. After 1 week in the cast, we can see there's increased glide of the long flexors, but he's not quite there yet. And after 2 weeks in the cast, we can see he has full restoration of that hooking motion. At this point, he was put into an intrinsic plus cast, which blocked his MCP joints into flexion in an effort to restore that full composite fist. So he's just working on pulling away from the cast in the video. And here he is after just 3 weeks of casting and 3 therapy sessions with full restoration of composite fist. So results we just would never have seen as quickly with traditional therapy techniques. The next case is a 65-year-old right-hand dominant gentleman. He sustained a traumatic partial amputation of his left index and middle fingers post a chainsaw injury at work. He had a 9-hour surgery to repair the structures, and he attended hand clinic 5 days post-surgery to commence hand therapy. And just a disclaimer, this next slide is a little bit graphic. So we can see the severity of the injury here, the number of soft tissue structures that were repaired, including long flexors, intrinsics, and nerve repairs. As well as the soft tissue structures, he sustained significant bony damage, requiring bone grafting, ORIF, and MCP joint capsular repair, and collateral ligament repair. So in this first video, we can see him 4 weeks post that initial protective splinting phase. So we see significant reduction in his range of motion, significant reduction in tendon glide. He has gross edema and very adherent scar tissue. We can also see when he tries to make a fist here, his wrist is overactive. His flexors are overflexing. So after 2 weeks in an intrinsic minus cast, we can see he's beginning to improve in terms of his glide of his middle ring and little finger. His index is still quite slow, but he required another few weeks in an intrinsic minus cast. He was then put into an intrinsic plus cast. I just don't have videos of that, unfortunately. But after 6 weeks of casting, he was able to engage in traditional therapy techniques. And here we see his final result. So it's by no means perfect, but given the severity of his injury, he's now got a fully functional hand. He's back at work as a forestry employee. So a pretty good result. So my last case is a 75-year-old right-hand dominant gardener. He was forced into retirement due to severe bilateral carpal tunnel syndrome and an ulnar nerve compression. He had multiple health issues, including bilateral degenerations affecting his ring finger and little finger. He had a history of poor function for 2 years. He did have a carpal tunnel release, and while he had much improved sensory symptoms post this surgery, his poor movement pattern persisted. So we can see a very good example of an intrinsic plus dominant movement pattern. And he was put into an intrinsic minus cast for a month. And I thought, given his chronic presentation, it would take much longer than this, but he worked really hard at it. And after a month in the intrinsic minus cast, you can see, I just don't have a video, but in these photographs, that he's full restoration of that hook, and his PIP and DIP joints are lovely and free and supple. And before the casting technique, they had really kind of blocky, hard end feel. So we can see he's a bit of a tremor just due to other neurological issues, but we can see a full restoration of composite fist here. And it's interesting, but given his chronic presentation, he didn't, even though he had a restoration of his movement and of his grip, it took him a while to start using his hand in a kind of an automatic, normal way, because he was so used to compensating with his right hand. And so it was nice in his final session just to see him kind of pick up his grocery bag and head out the door.
So case 4 is a 58-year-old left-hand dominant lady. She slipped in the shower, resulting in a spiral fracture of her left third metacarpal, which required an RF with lag screws. So despite early protected mobilization and edema management within 5 days of her surgery, she really developed significant stiffness and swelling very early on. Just of note from her x-ray, she has some OA changes, in particular of her DIP joints of her index and her middle finger. So this lady was adamant she did not want SIMS. So instead, we went through 7 weeks of traditional hand therapy, which, as we all know, is a huge time commitment from both the therapist and the patient, and involves, various exercises, splints, contrast baths, massage, edema gloves, as well as attending therapy weekly. So this lady took a break from therapy over Christmas, and when she came back, this was her movement that you see in the video, and her quote to me was, "Put me in the cast or go." So I put her into a cast. So she was in the intrinsic minus cast, and she was in this for 3 weeks. And then she went into an intrinsic plus cast, and she was in this cast for 2 weeks. And following on from this, she went into exercise casts. And this was her final video. So we can see she has a good functional fist. There's still some limitation, in particular of her middle finger DIP joint, but really this is probably from her OA more than anything else, but she was very pleased with her outcome. Case 5 is a 36-year-old right-hand dominant labor. He had a glass injury resulting in laceration of FDS and FTP of his ring finger in zone 3. And this was his movement after 9 weeks of traditional hand therapy. And at this point, he was referred to me for consideration of SIMS. So just to say, this was my first SIMS patient, and boy, was he a challenge. And luckily, I had Robyn helping me with his first session. So because he had such limited motion, initially he required a cast all the way up to the DIP joints with the dorsal foot. And this provided proprioceptive feedback for him to move away from the foot. This allowed a really brilliant extension stretch on his MCP joints and focused flexion through his FTPs. He then, after this, went into an intrinsic minus cast for 3 weeks. Then he went into an intrinsic plus cast for 2 weeks and exercise casts. So this was his motion following casting. So we can see he's much better extension. He has much better flexion, but he isn't perfect. He still has some stiffness. But for this gentleman, SIMS really kick-started his rehab and allowed him then to continue with more traditional hand therapy techniques. And this was his final outcome. He returned to work as a laborer, and he really would not have got this outcome only for SIMS. Case 6 is a 53-year-old right-hand dominant woman. She had a Dupuytren's fasciectomy of her left ring finger, little finger, and thumb. And unfortunately, she developed CRPS and significant stiffness after surgery. She had traditional hand therapy for several weeks in another institution, and then she was referred to our hospital at 6 weeks post-op for a specialist opinion. This lady was a little bit tricky. So she has chronic low back pain, and how she manages that is by swimming every day. So she wasn't going to commit to wearing a full cast. So the first time I saw her in clinic, I made Robyn's design, which is this POP cuff. So it works similarly to an intrinsic minus cast. However, it's removable, and usually a cuff would be used for somebody with a lot less stiffness or from somebody who is weaning from the cast. So she actually made quite good progress after 2 weeks in the POP cuff, but we can see she still has quite a lot of significant stiffness, and she's pointing to her wrist there. She's getting quite a bit of wrist pain as she moves. So again, she still wouldn't commit to a full cast, so we compromised, and I made her a removable exercise cast, and she was really diligent. So she wore this all the time except for swimming. So she wore this for 3 weeks. She then went into a removable intrinsic plus for another 2 weeks. And then this was her outcome when she came out of her cast. So although she was in a removable cast, for her, because she was so committed, this actually really worked for her. And it was nice to see. She sent me a photo of her hand. She was on her holidays in Spain, and we can see that she's maintained her movement despite weaning from the cast. So we audited 25 of our patients, and we assessed them pre and post casting. We looked at their movement patterns. So initially, obviously abnormal, whether it was intrinsic plus or minus or normal. We looked at the quick dash, their total active motion, and the number of weeks in a cast. So looking at their movement pattern, most 95% of patients had an intrinsic plus movement pattern. Everyone after casting had a normal movement pattern. So looking at this slide, this is the quick dash. So remembering that a higher percentage means worse function. Purple is pre-casting and blue is post-casting. And we can see that post-casting, there was a significant improvement in function in everybody. Then looking at TAM. So if we look at pre-casting, we can see that the majority of patients had poor TAM, whereas post-casting, the majority of patients had a good TAM.
You can also see in terms of the number of weeks patients spent in CAS, that the average number of weeks was 4.5 weeks, but it ranged between 2 and 9 weeks. And that was very much dependent on the type of patient you had coming through the door, whether it was a chronic case or more acute. So the patients obviously with more chronic presentations generally tended to need longer in the CAS. So in summary, following the audit, all patients had a normal movement pattern post-casting. 92% had a good outcome in their TAM, and there was an average 79% improvement in quick dash. So unfortunately, there's limited published evidence on the use of this technique in the literature. So we just hope to keep building our numbers in this case series and ultimately publish. And in conclusion, CMMS provides a time and cost-saving treatment. It results in reduced face-to-face visits, reduced length of treatment episode, and it's a brilliant option to kickstart therapy, particularly with complex upper limb presentations. It's really been a game changer in our practice, and we hope that if you're not using CMMS already, that you'll consider learning the technique and seeing the results. So we hope you enjoyed our presentation. Robyn did ask us just to give a bit of an overview of the conference. We were the only presentation on CMMS at Rimini. In one of Don Lalonde's presentations, he included CMMS as a treatment option for conservative management of adherent flexor tendons. And he was kind enough to mention a presentation we gave on CMMS at the Irish Surgery Society meeting earlier this year in March, where he was a keynote speaker. So there was a huge amount of topics covered across the few days of the conference in Rimini by therapists and surgeons. But for the purpose of this presentation, we'll just focus on CMMS. So our presentation was well received, and we got lots of questions, and Emma will just run through a few of them now just to give you a flavour of the covered. So one of the questions was, can you use thermoplastic? So we know that you can't. It only works with POP. And I gave the example of a patient of mine that was in a cast for 9 weeks, and after removing her hand from the cast, her skin was perfect. Another question was, does it improve passive range? Does passive range improve with an active technique? Again, as we know, it does. So an active technique such as CMMS can improve both passive and active range. Another question was regarding extension loss while in the cast. So we explained that we use a thermoplastic splint at night over the cast to prevent the development of POP joint flexion contractures, and this works really well. Another question was, how do you get the patient to buy into using the techniques? Well, for us, the main thing that's worked for us is actually showing patients videos of other patients. So showing them their hand before the cast went on and how stiff they are, and then showing the cast itself and how they move in it and their outcome afterwards, as well as really explaining the rationale behind it. Another question was, is this your treatment of choice now for every patient? So as we know, it isn't the answer for every stiff hand. Personality must be taken into consideration, and the person's own circumstances. And that can, change your decision about what is best for this person. But certainly with patients that have that abnormal movement pattern, nothing really works as effectively and efficiently as CMMS. So the overall response was really positive. But I think in order to get buy-in on a bigger scale from therapists and surgeons, we need more published case series that showcase the effectiveness in CMMS in the treatment of stiff hands. And hopefully now with more and more therapists using CMMS,
this is something that will happen over the next few years. Thank you very much.
Thank you.